Hi, it's Rob Arnfield speaking to you, and this will be the screencast covering the fundamentals of ultrasound-guided vascular access. As a complement to your ICU junior resident rotation, this will be one of the most important procedures you'll perform throughout your rotation and one of the most frequent procedures you will perform as well. So I ask and thank you for your attention as we go through some of these details. This screencast and a broader curriculum of screencasts will cover the following elements: fundamentals of vascular imaging, including ultrasound machine controls and probes, how to actually do this in a sterile fashion, which will be covered in a separate screencast regarding sterile technique, the techniques of actual cannulation, primarily relying on the short axis, as you'll see, and review of some expanded vascular access sites, i.e. other than the IJ, we will cover as well in an additional screencast. I'd like to acknowledge many of the great audiovisual materials in this presentation come from Dr. Arun Nagdev, who is featured here, and he is the Director of Emergency Ultrasound in Oakland and an excellent ally and an excellent educator. So thank you, Arun. Of course, the goal will look something like this at the end: calm, poised, ultrasound guided, sterile, rapid. All those things will be actualized after you sink your teeth into this material and get some hands-on practice. Now, I'm going to prime you for something called the creep technique, which we'll come back to later, that is depicted here. And I want to allow you to think about the spatial and three-dimensional nature of ultrasound in the way that each ultrasound image here corresponds to the picture below, and how oddly each time the beam intersects with the metal, it looks the same, though the part of the needle that is being displayed is quite different. So that is the challenge of vascular access, and to do it at the highest possible level. More on this later. So I expect many of you have done ultrasound guided access, and I think it's important to recognize that many of you, I expect, will have done it in this approach, where you have a nice image of the carotid and the IJ here, and you can see tissue wiggling, but you see either no evidence of needle tip, as is in this case, or often what you might mistake for the tip that is not actually the tip. And that comes back to the creep technique, which we'll talk about in a little bit. So I would argue that this is not a satisfactory approach to vascular access, and that if this were my loved one, I would like you to know exactly where the piece of metal you are using to pierce the flesh and blood vessels is located, rather than simply relying on the trajectory that you can infer from this ultrasound-guided image. And this is further echoed here, as you can see the operator in this case is desperately trying to, it seems, to go through the back wall of the IJ into the carotid. And for all we know, this part that we're seeing here with the needle, we don't know which part of the needle that is. For all we know, the carotid could already be perforated in this exact situation. And that is a common situation, according to this paper that looked at well-trained residents who actually went through the back wall of the IJ frequently in a simulation-based scenario in the majority of cases. So very interesting. And so no one's above this. And so I think no matter where you are on your learning curve with vascular access, hopefully we can move you a step up. Now, going back a little bit to talk about something called the blind technique, or the ultrasound unassisted technique, it goes without saying that this is now a standard of care, and that's largely because of the mechanical complication rates associated with internal jugular access that can be mitigated by the use of ultrasound. So accordingly, I think we can confidently say, and I've been saying this now for 5 years, but I still feel the need to say it, that the blind IJ technique is dead, and that if you are an accomplished sort of acute care physician with your own practice, a lot of what you're going to learn here is going to hopefully enrich your own practice, but also provide you with the techniques and terminology to teach others how to do this in the safest possible fashion. And if you're a junior or even a senior resident watching this, I think this will inform you how to do this technique properly. Now, the equipment you'll need for this procedure, of course, is the machine, but the transducer of choice will be a linear array transducer, or the vascular transducer, as it's commonly called, used for its very, very high frequency and corresponding ability to really depict the needle and the vessel very vividly. By comparison, you can see on the right here the same image, this vascular image here, compared to this one here, obtained with a curved linear probe, though at a similar depth of 4.7 to 3.1 centimeters, the anatomic detail is really all but lost for a near-field structure such as these vessels. So we will always choose the linear array when doing ultrasound-guided vascular access. A little side note on artifacts, in particular the ring down artifact, which is a vertical hyperechoic mark that you can see often that comes from tissue or fluid vibrating in the lumen of the needle during cannulation. It can pose a hazard, as you may mistake it for the needle when it's actually an artifact. So just be on the lookout for the ring down artifact that you could come across in your hands-on practice. Now, the orientation of the probe is paramount, of course. When you're sticking needles in people, you need to know which side of the screen to expect them to come in on, and when you turn right, that the needle should also turn right, and vice versa. The index mark on the probe maps that side of the probe to that corresponding side of the screen, and that's a three-dimensional concept that, if you aren't unfamiliar with, should become apparent, again, with some hands-on practice. And if you're ever disoriented, and many of us will just do this, even though we have a very systematic way of doing this, we'll just tap the transducer to be doubly sure that we're aligned in space the way that we think we are prior to engaging in the invasive procedure. Another example here, you can see the index mark of the transducer should generally correspond to the same side as the index mark on the screen. So if the machine is downstream from you, you're standing at the patient's head looking towards the feet. If the machine is in front of you, as it should be, the index mark generally on the screen will be on the left side of the screen, and the index mark on the transducer should be aligned with that index mark that is oriented towards your and the patient's left side. That way everything is lined up, and the needle will come in where you expect it to and will move the way you expect it to when navigating it in vivo. Now, with particular attention to the IJ, you must know your external anatomy, and using ultrasound is not an excuse to simply put the probe on, find a black circle, and stick things at it. You must be aware where you are in the neck and, of course, the neighboring structures. So if you're teaching this or you're learning this, be certain to be aware of neighboring structures: carotids, thyroids, airways, sternocleidomastoids, lung apices, bifurcation of carotid arteries, etc. Now, to produce an adequate 2D image, of course, you must set up for a procedure as you would at any other procedure. And in particular, I would like to emphasize the need for an extra set of hands to help you get the probe into the sterile sheath and to help you operate the machine once you're set up and sterile. And the other big thing to do, of course, is to talk about how to put the probe on the patient, how to look around to see if you are in the right on the right side of the neck or the correct side of the neck to do the procedure. And to do this, I suggest pre-screening patients rapidly before you get sterile in the short axis technique in a fashion such as this. You can see this operator has non-sterile gloves on and is just simply having a quick look on this patient's right neck to see, is the IJ suitable? Is it located in a favorable location? Is it a good size? Does it have a clot or thrombus in it? And having a good look around, because before you get sterile, you might like to make sure of this so you don't get caught switching to another site or another side. So once you've got a basic image on the screen, you're going to optimize and analyze, of course. You want to make some of the assessments that I've just mentioned, and some ways of optimizing your image would include head position, the depth and gain on the machine, and you can actually change the vessel size by most commonly using Trendelenburg, but in a cooperative patient able to do a Valsalva maneuver, for instance, that can really be a big help, as I'll show you in a little bit. And as mentioned, you want to analyze and look for pitfalls or for hazards along the way. Of course, the advantage of being able to see before you stick anything in people is you can have a good look around and look for these kind of problems. Now, you want to be clear which is the artery and which is the vein, and anatomic relationships are usually preserved, but they aren't always preserved. And really being faithful to some of these factors that can distinguish arteries and veins will serve you in good stead. I can guarantee if you do enough of these that you can really avoid the hazardous complex line insertions or know how to navigate them. So things like the compressibility of veins, the respiratory variation. And if you're an advanced user, you can break out some Doppler concepts, though ideally, again, that's only preserved for advanced users with comfort both with Doppler and with significant experience with vascular access. Now we're moving on finally to this creep technique, which I've alluded to. Now, the creep technique is one that involves the progressive advancement of your ultrasound probe just beyond the needle tip, and then moving it back to just intersect with the needle tip. And this way, you'll, as I'll show you in a minute in a live video, be able to be certain always what the leading point of your needle is, and therefore never go in too far, and always be certain exactly where you are in space, which is uncommonly the case. Because if you look at the schematic, if you just put the probe on here with a needle tunneled under the flesh, you will immediately see this hyperechoic spot on the ultrasound screen. You say, oh, well, there's my needle tip. That's the natural assumption everybody makes. You say, oh, there it is. And you start advancing your needle with assuming that you've got another, say inch or whatever of depth to advance. Meanwhile, your needle's actually already, if this is black thing is the vessel, already through the back wall. And this is the hazard that people get into. So the way to get around this is to advance your probe, advance beyond the tip of the needle, and such that this is your ultrasound screen display, and then move it back to be confident that this is then the distalmost portion of the tip. And that way you can then advance your probe again a little bit beyond, and then advance your needle into the field of view of this one, and you slowly do kind of a back and forth approach, which I'll show you again on an ultrasound image. Because otherwise you end up in this case. We assume this is the tip of the needle. We assume that hyperechoic lesion, or spot rather, on the at the IJ there is the needle, but we have no way of confirming that unless the operator has done what I've just described, in which case I don't expect it to be frantically pushing on the IJ the way they are. So we'll go through this again here. So you can see that as you image through here, this is the shaft, this is the shaft, this is the tip, and this is the BTT point, or the beyond the tip point. And the only way you can know that, of course, is to actually go beyond the tip such that you no longer see any metal or any hyperechoic spot on the screen. And then the first hyperechoic spot you see as you come back towards your needle will then be the tip. The next step then is to advance your probe a little bit, either angling or physically sliding the probe down the neck of the patient just beyond the tip, and then advancing the needle into your field of view such that it appears on the screen. Now we have a real-time example here that I'll repeat for you a few times, and what you'll see here progressively is the operator seeing the tip, advancing the probe, advancing the needle, advancing the probe, advancing the needle, and advancing the needle again just into the vessel. So this kind of song and dance maneuver where the operator is clear at all points exactly what the leading edge of their needle is doing, and so is clear they will never, ever, ever go anywhere they don't want to go, which is an incredible, incredible gift to your patients and a fun way to do the skill, because you'll find you can get a needle almost into any space if you use this technique called the creep technique, or call it what you will. Needle, and we know it's the tip each time because each time the operator moves the ultrasound beam beyond the hyperechoic spot just a little bit, and each time slides the needle back into the plane. So this is really, really expert stuff, and what I hope all you can achieve. Other ways to improve your image, as I've mentioned, Valsalva and PEEP. Head positioning is an interesting one. Many people tend to crank the head all the way to the side, and that's actually likely to worsen the orientation of the IJ and the carotid together. So under real time, of course, you can change the head position and before you get sterile, and see which head position works best for the location of the carotid relative to the IJ. And you want to play with your depth and gain. So here's a great example of Valsalva maneuvers power to change the caliber of a previously virtualized IJ into quite a large and plump IJ in this patient. And so, what do you do once you get flashback? How do you ensure that you're not in the carotid? Well, the best thing to do, of course, is to put the guide wire in before you cannulate, and then look to see this hyperechoic stripe nicely penetrating through the IJ. So we'll do this once more. It starts on short axis, and then you turn your probe 90 degrees to the long axis. And then there you go. You see the guide wire sitting in your vessel. Beautiful. So let's talk about long axis approach. Everyone loves the long axis approach. I mean, look how pretty that is, watching that needle go into the phantom vessel there. You can see the needle whole way. None of this creep technique. It looks so awesome. It's great. But the question, of course, I have for you is, where's the other vessel? Where's the carotid that we're trying to avoid? I mean, remember, the very point, or one of the major points of ultrasound guidance, is to avoid the carotid. By using the long axis, you discard this information, and you effectively, I think, reintroduce some risk, particularly because this depiction of the long axis as shown here is not often real life. Lining up the needle in long axis perfectly with the ultrasound beam is much like lining up two credit cards or two thin pieces of paper to sit on top of each other. It's actually quite difficult to do, and I would suggest this is an expert or advanced user approach, and would suggest that this is much more what real life looks like. You have a more faint image of the needle. You have the vessel on long axis. We don't know where the carotid is, and at this point, we're not sure if we're in, because we might be a little bit out of plane. We've actually, we might be in two different planes here, even though we're still in the long axis. So it's a bit more challenging. I would suggest stay away from this, aside from in phantoms or in simulated scenarios, until you're really quite comfortable. There is an alternative approach called the oblique technique, which kind of uses both the long and the short axis approach together with the probe on a 45-degree angle. But again, I would suggest that's reserved for people who have a fair bit more experience in using ultrasound guidance. And once you master the creep technique, you'll never have want really for any other techniques, in my opinion. Now, the femoral approach is easily done. The inguinal crease is the place to put the probe. Again, the index mark rules with the probe and the machine apply, line them up so they sort of are aligned, pointing in the same direction. And the vessels and the anatomy are as you remember them from the blind approach. Now, the vein, as seen here medial to the artery, which looks like it's bifurcated here, is easily struck. The interesting thing is the saphenous vein up there is commonly hit during a blind approach, and explains many of the times that you're unable to thread your guide wire or to get your cordis in. It's because you may be in a branching vein of the femoral vein. So other pitfalls to be mindful of. Biggest one I would say is overconfidence in your ultrasound findings. You see a spot on the screen, it looks like it's in a vessel, and believing that even though you have pulsatile blood or a gush of air preceding that or after that, that you're in the vessel. So please, as best as you can, try to be very humble in your findings and recognize this is a new skill for you, taking in multiple data points while performing a complex set of interactions with needles and Seldinger technique and sedated or critically ill patients. So just, a little bit of humility up front will go a long way. We often see a spike in complications for early users of ultrasound guided access because they start ignoring their basic senses regarding where their needle might be or where they are in the neck. The other things to be mindful of are the clot in the lumens, or if the vein is too small, or other pitfalls that I've mentioned. And here we'll look at a couple of those. So here you can see a clot in a previously cannulated IJ in an ICU patient. You can see some wisps of clot and complexity there. So the right answer is always to pick another side. Though we don't know the morbidity of cannulating at these sites, we expect it doesn't bring good favor to the patients. And this is an interesting case from ED from a few years ago. You can see after first attempt, there's a carotid there, and the IJ is somewhere up here, we believe. I was asked to have a second look at this, and what certainly I was able to deduce was that after an unsuccessful poke, inability to pass the guide wire, there was a massive hematoma here now along the back wall of this IJ that's compressing it and making it very difficult to gain access. And many of you will see this as you sweep up and down the neck, and you'll recognize this valve structure right at the base of the IJ as it enters into the subclavian. And if you're seeing that, that's great. It's just a valve. You don't need to worry it's a clot. But also be mindful it means your probe's way too low on the neck typically, and you should move it back up to about the height of the cricoid cartilage, where you'd probably like to cannulate under most circumstances. Confirming your guide wire, I've mentioned already. You can also confirm the actual catheter itself, perhaps obviating the need for radiography after after placement. And you can see the cordis here entering the IJ with the carotid and long axis. It's always easier to confirm the presence of the guide wire or the cordis itself using a long axis approach. When there's extreme turbulence in the vein, as in the case of, say, SVC syndrome or other unusual diagnoses, probably best not to stick thrombogenic catheters in the midst of a clot in process, as you can see here with the spontaneous contrast in the IJ. And perhaps the ultimate technical difficulty or complexity is this patient receiving CPR with their IJ lying directly over top of their carotid. This is an immediate invitation to perhaps choose another site or to lower your expectations in the context of cardiac arrest. I would favor the choosing another site, either a femoral approach for good reason or a subclavian approach. Please remember to maintain the machine, especially when it comes to invasive procedures, and especially with the mortality rates that we know that central venous catheter infections can produce. So please, please, please clean the machines for the sake of your colleagues and your patients. So in summary, you're going to use ultrasound guidance from now on. We're sure of this. You're going to use the short axis, I hope, and the creep technique in all its glory. It's a fabulous technique. Needle tip control from that technique will allow you to cannulate veins, arteries, peripheral veins, even entertain regional anesthesia techniques, tapping of joints. The tip visualization, as long as you master that, you can become an excellent needle wielding physician or provider. And I strongly emphasize confirming your guide wire before cannulating anything, and beware of your overconfidence and the overconfidence of others. So thanks very much for your time, and I hope this is useful, and we'll see you shortly to do some hands-on central venous access.